All right. So, today we just wanted to kind of start off the conference and look at more non-oncologic hardcore topics, that is infection. And of course, Subra was there. I wanted to again present this protocol that we've been developing for almost 6, 7 years now, and for high-risk febrile neutropenia. And I want to show some of our data. I call it the Maggie protocol because it's easier to remember that way for everyone. Some of you might have already seen this, and many of you would be aware of the clinical syndrome that I'm talking of, which essentially is neutropenia. We all know that normal absolute neutrophil count or safe absolute neutrophil count is more than 1500. It's when it starts dropping below 1000 and then ultimately below 500 and 200 is when our patients behave like sitting ducks. They practically have zero immunity, and the normal flora, microbial flora in the body, most of which is in the colon. The large intestine is full of trillions of bacteria. And in fact, I've read somewhere that we have more bacterial DNA in our body than human DNA, right? So is this a human body with bacteria or bacterial body with some human cells in it? That's the kind of the philosophical question. Our patients look deceptively, stable. Even with very low neutrophil counts, they may not have any problem. But then suddenly they become, they get one spike of fever or they start having cough. Um, we see this in almost every patient who gets high dose chemo. Whatever the data says, 100% of patients with AML are going to get an infection because their WBC counts go down to zero for all practical purposes. And the flora, which is in the gut or the airways or the skin, will activate and will target and cause infections. The most important thing is because there are no neutrophils, there are very few signs and symptoms. These patients can go from being stable to dead in 6 hours. All of us have stories of such patients. So it's very difficult to know when to start treatment, how much to escalate, what kind of aggression should we have. And normally in patients with normal immunity, the concept of antimicrobial therapy is you start with the lowest antibiotic, and depending on the response in 2 3 days you go on escalate. However, in patients who can die, so neonates and neutropenic patients, right? In these two categories, the strategy is of de-escalation. So you hit hard with the best available antibiotic, and then based on the culture or the PCR, you kind of downgrade because you don't have time. In 2 3 days, the patient becomes too sick and goes to ICU. And once sepsis syndrome sets in, it's a losing game. That's very important. Sepsis as a clinical syndrome has two phases. The first phase is a pro-inflammatory phase. And then the next phase is a reduced inflammation. And when the patient tips that peak is when they go out of hand. After that, you can do whatever you want. Once that phase sets in, you are not going to be able to salvage your patient. And very soon there'll be multi-organ dysfunction, and that's about the end of it. So that's why this syndrome is very important, and we all struggle with this, especially because in our country, we are not able to identify the bug. Best case scenario in a wonderful hospital, great microbiology lab, doctors and nurses sending blood culture before the first dose of antibiotic, sending 5-10 ml of blood, aerobic, anaerobic, whatever you do. This is the best case positivity of blood culture. It's a very insensitive test. You're not going to get more than 15-20% blood culture positivity anywhere in the world. which means 80 to 90% of your patients, you're treating them blindly. You don't know what is the bug, leave alone what antibiotic to use. You're blindly throwing antibiotics at them. And if antibiotics don't work, you throw antifungals at them, right? That's the policy. The second problem is antimicrobial resistance, especially critical in developing countries, because we have ciprofloxacin, gentamicin being sprayed on farms, being fed to chicken, right? And because these antibiotics are there in the community being sprayed on farms, to reduce infections of crops, and then chicken and cows, they seep into the groundwater, and there is intake. The bugs are in the ground, in the soil, are already resistant. We swallow these antibiotics with our food, whether you are a vegetarian or a non-vegetarian, and hence resistance to most of the routine antibiotics in the community is very, very high. We don't have regulation to cover all of this. So, antibiotic resistance kills at least 7 lakh people per year, not the cancer. Okay, antibiotic resistance. And I'm sure it's double because, from our country and Africa and Southeast Asia, we have absolutely no data getting reported. But this is where we have maximum problem. In our country, this is what we are seeing. Meropenem, imipenem resistance is more than 50%. And if half of your bugs are resistant, there's no point in using that antibiotic as first line. That's a core concept of infectious disease. If half of your patients are going to fail your treatment, why use it, right? Then we started adding polymyxin and colistin, right? Almost 10 years ago, all of us started using it. But they are bacteriostatic drugs. They have their own side effects, but they're bacteriostatic. They're not very strong drugs. You have to combine them with meropenem. And today, as we track the antibiotic resistance, about 40% of the bugs in our country are resistant to colistin and polymyxin also. Mind you, some Klebsiella and E. coli species in some centers, 80% of them are resistant to meropenem. Right? And when we hear such statistics, I remember when I was in training in hematology, and there was some patient for whom one of the residents had started penicillin. Okay, and this was, I think, 2004. So 20 years ago. So that time we were talking about penicillin. Today we are talking about piperacillin tazobactam. Yeah. And, my boss, Dr. Maman Chandy, he said, no self-respecting bug is going to respond to penicillin. Right? It's just not possible. So it's ridiculous. Some of the things we have to understand. So all of us have, whoever manages hemonc and transplant patients, if you look at what happens in the world, depending on which center you look at, about 10% to 40% of patients die because of febrile neutropenia. Depending on what kind of complexity you have, the infection control practices, the hygiene, the crowd, the nursing, the shortage of nursing, the shortage of doctors, your mortality is going to go towards 40%, right? So we started about 7, 8 years ago saying, no, let's aim to bring down our mortality to less than 10%. And the basic platform which I said, well, we have to use are the IDSA guidelines, which is the Infectious Disease Society of America, still not updated, 2010 guidelines. Divide patients into low risk and high risk febrile neutropenia. Low risk patients are those where the neutrophils are going to recover in a week. Simple. High risk, where the neutrophils are going to be low and the patient may have comorbidities, right? So we said low risk is very easy. Often, there are patients who are receiving ABVD or R-CHOP or some dose chemo, and you give them even oral antibiotics. We don't even have to admit most of them. So let's focus on high risk. Low risk, if they're stable, nothing to do, we don't even admit them. What about high risk? We decided that in in the rest of the world, even today, for neutropenic patients, they use antibiotic prophylaxis with ciprofloxacin. Probably 100% of the bugs in this country are resistant to ciprofloxacin. So we decided we are not going to use any antibiotic prophylaxis. It's going to be useless. Of course, we continue to use, HSV prophylaxis with valacyclovir or acyclovir and antifungal prophylaxis. I'm going to revisit the fluconazole for ALL because recent guidelines actually last month are saying that, and these are the European guidelines, that for ALL and autologous transplant, you may not use anything. You don't even have to use fluconazole or mica fungin, which we have been using, but probably next month we are going to change our policy. So this was our prophylaxis. And I said, all right, we are going to follow this. And this has been incremental. So, first we tried out microbiology and antimicrobial. We learned, in fact, Subra helped me understand this quite a bit. GCSF, everybody uses. But we changed to PEG GCSF. So we don't give daily GCSF anymore. We use pegylated because it gives a very sustained rise. And, one injection, yes, it's more expensive, but the yo-yoing of WBC counts that you see with routine GCSF, you just don't see with this. So we've changed to PEG GCSF almost 5-6 years ago. We decided to try out granulocyte transfusions because there are some early data from Dr. Samir Melankari from Pune saying the mortality comes down and ICU transfer rates come down. So I said, all right, let's try that. And then, of course, all of us do this early IV access removal. If there is any suggestion of a CRBSI catheter related bloodstream infection, you will remove the PICC line or central line and early transfer to ICU. So microbiology actually was the first thing which hit me, in terms of how much I did not know. We all do this. We all send aerobic and anaerobic two sets, at least 5 ml, maybe 10 ml of blood. But it is the molecular PCR panel which opened my eyes to the fact that we can improve mortality even though antibiotic resistance is growing. Okay. And this is the cost. So most of the people say, are you sure you want to spend so much? Right. I also learned from Dr. Arunalok from PGI Chandigarh, where he is a phenomenal mycologist, that if you have a febrile neutropenia patient with any lung infiltrate, you do an early bronchoscopy BAL and the survival improves dramatically. So he actually presented this data in one meeting. He had come from Chandigarh to Bangalore. And I said, all right, we will start doing this as well. We were, of course, worried because most of the pulmonologists were scared to put a scope in patients who, who had zero neutrophils or 5,000 platelet count, etc. But slowly, we managed to convince them. And now we have data on about 75 odd patients, which will be publishing very soon as to what we have found. Let me give you some details about PCR. There are many labs which do this, and we have tried out various labs. We have helped them create these panels. We've helped them validate these panels. We've kind of figured out there are only 2 labs which do this properly in this country as of now. Most of the multiplex panels have, the common gram positive, gram negative, some fungi and some viruses. And we worked with them to add some more organisms in this based on our data. This is our first publication. Our initial analysis of 34 episodes of febrile neutropenia. I think there were 18 patients or so. And straight away, you can see that blood culture positivity was only 12%. And with multiplex PCR in 30% of patients, we could identify the infecting organism, right? We looked at whether there was correlation. There is always a question of no, PCR is too sensitive. PCR is too sensitive and you are going to get false positive, etc. Let me show you some things. So we continued this after this initial study, initial analysis. I protocolized it saying every patient with high risk febrile neutropenia Day one, first spike of fever, we send two cultures and we send a multiplex PCR panel. Of course, if the patient can't afford, what to do, right? What I did not present here is in the first paper, we also did a cost analysis. What we learned is because the PCR, suppose it gives us Klebsiella, culture is negative, we did not know what was going on. So the patient was on teicoplanin plus meropenem plus colistin plus amphotericin or caspofungin. But when the PCR gives us Klebsiella, I started stopping other antibiotics and antifungal, which is the critical thing. Exactly what Subra said. It's important to de-escalate or stop what is not grown in culture and what is not there on PCR. So in this analysis, we actually saved 75,000 rupees per patient by doing a more expensive test in the beginning, which actually helped us in stopping most of the antibiotics. And as we protocolized to do this with the first spike of fever, and these reports are available in 24 hours. So by second day of fever, we know, what to stop. And because we are giving the right antibiotic on second day based on the PCR, we had less number of patients deteriorating to sepsis, less number of patients going to ICU, less mortality, and of course less cost, because ICU cost is crazy, right? ICU cost is crazy. So I protocolized it, and then we analyzed data on 271 more patients, and we presented this in the National Hematology Conference. You can see a smattering of hemonc and aplastic anemia and transplant patients. Those were the indications. This was the positivity of blood culture. So you see, by protocolizing and focusing, even our blood culture positivity had improved, because the entire team, including nurses, doctors, became trained and tuned that no, you have to take blood culture, and within 1 hour start the antibiotic. Within 1 hour of the fever, you have to start the antibiotic, right? And with just that kind of OCD, our blood culture rates also improved. Yeah. And that's the positivity of multiplex PCR. So now more than half, 55% of patients, we're getting the bug. So you see the first 34 samples, some samples were sent on day 3 or day 5 or day 10. When the patient is not responding, we thought, okay, we will send the PCR now. So when you send late, even your PCR positivity is going to come down. But when you send it on day 1, more than half of the patients. So you see, earlier we were giving antibiotics for 80-90% of our patients blindly. Now, half of our patients, we know the bug, and we have the diagnosis. We send blood in the majority of patients. That's the positivity in the blood. And like I said, we send BAL. Now, this is our experience. If our patient with high risk febrile neutropenia has any respiratory symptom, mildest of cough, we do a CT chest. We don't do X-ray. We don't do X-ray. If the CT chest shows smallest of infiltrate, that day we do bronchoscopy. So now our system has become such that our, CT is done. We look at it, we call the radiologist, they say, yeah, there are some infiltrates, but I don't know what it is. We say, yeah, don't worry, nobody knows, right? We have to do the test. And then the nurses arrange the platelets, they give the platelet, we tell the pulmonologist, please come and do bronchobal. And then we send the BAL sample for all cultures and multiplex PCR. 95% positivity. Immediately, within a day or 2 days, right? What used to happen earlier is for the first 1 week, 10 days, there's nothing is seen on X-ray. So we wasted 7-10 days. And then we do an HRCT chest. And then the radiologist will say, could be fluid overload, could be fungal, could be bacterial, could be viral. They're just guessing. You are not going to get major infiltrates because there are no neutrophils to create infiltrate. You see, lung infiltrates are an inflammatory reaction, which means your rubor, color, dolor, and all that. And for that inflammatory reaction, you need neutrophils. By the time you get a lung infiltrate, it's too late, right? We do it early, still 95% positive, right? And those are the different bugs. What we saw in blood culture, what we saw in the multiplex PCR panel, and it's the usual. Gram negative, gram positive. We did pick up some rare patient, bugs, One patient who was on high dose steroids for autoimmune cytopenia came with a calf ulcer, abscess, calf abscess and fever. Okay. Been on prednisolone for 6 weeks and azathioprine and all that and mycophenolate. Turned out to be salmonella on PCR. Who would have thought typhoid will present like that? Right? Just a cough, because these patients, they're going to give you very weird presentations. We had one COVID that we detected. I mean, retrospectively, I realized it was a COVID that we detected, I think in 2016 or something. It was, of course, not the COVID-19 strain. It was a different strain of coronavirus. However, the problem with multiplex PCR is if you don't have the primer for the bug, you're going to miss it. So culture is still important. We had an outbreak of Burkholderia, and Burkholderia was not in the panel. So the multiplex PCR, expensive multiplex PCR missed it, culture caught it. So then I had to convince the lab to add Burkholderia primer in the PCR, right? So that's how we worked with the labs to improve these panels. Most of our patients, we are actually, 42% we are changing the antibiotic based on these reports. Culture still 20% positivity, like I said, we use it to change our antibiotic. 1/3 of our patients where nothing is positive, we're still using clinical judgment, blind therapy. Antibiotics, to be very strict, within 1 hour of onset of infection, and this is kind of our policy. And whenever the fever doesn't recover, come down in 2-3 days, we have to change, etc., etc. All of us do that. Gram positive cover, we all know the usual indications. I don't have to go through that. And if the culture is negative in 2 days, we stop gram positive cover. So all of that you have to do. However, what made a big difference for us is granulocyte transfusions. Again, based on some data, what I felt is there's no point in giving granulocytes when the patient is sick and in ICU. At that point, if you start granulocytes, then it kills more patients. It kills more patients because already there is such a cytokine release because of sepsis syndrome. And you're giving neutrophils, right? You're giving outside granulocytes, borrowed soldiers. And these are going to release cytokines. And there's going to be pulmonary edema. And the patient is going to actually become worse lungs-wise. So we thought, what if, just like blood transfusion and platelet transfusion, right? You don't wait for platelet transfusions, platelets less than 5,000. You don't wait for the patient to bleed. Hemoglobin less than 7, 8, you don't wait for the patient to go into congestive cardiac failure. Similarly, what if we give granulocytes early? So the protocol that we created is high risk febrile neutropenia, okay, not low risk. So AML induction, consolidation, autologous allogenic transplants, and salvage chemo. 5 indications. High risk febrile neutropenia. On the day of first spike of fever, we take cultures, multiplex PCR, and before admission, you screen the friends and relatives of the patient. You identify 4 or 5 blood group matched young donors who are willing to go on apheresis machine. Okay. So the day, and of course, we also, so we would, Ashish did all of this work as our transfusion head. So we would say, all right, patient's blood group is A positive. We want 10 A positive young people. And then we'll counsel them and keep them ready. And in fact, blood bank would have already screened them for HIV, hepatitis, blah, blah. So ultimately, you have 2, 3 donors who are, motivated and healthy enough to donate granulocytes. So first day of fever, first spike of fever, we call the donor, all right, now you come, take GCSF injection at night, take steroid at midnight, come tomorrow morning, go on the apheresis machine, and we harvest your granulocytes. So next day evening, second day of fever, we have granulocytes. Patient is stable, right? And we decided we will do this 2 days in a week. Very little logic in that. But if you see half-life of neutrophils, and if you see that whatever is published, granulocytes are given on alternate day or once in 2, 3. So we thought we'll give, if you start on Tuesday, you do it Tuesday, Friday. If you start on Wednesday, you do it Wednesday, Saturday. Okay. And if the patient has hectic fever in the beginning itself and is becoming sick, you give it alternate day. Okay. So 2 to 3 granulocyte transfusions per week. And I don't have the data now because we are analyzing, but our ICU transfer rates came down from 40% to less than 10%. They don't become septic. You are giving them what they are lacking. Febrile neutropenia is because of neutropenia, right? So you give neutrophils, they don't become septic. Our ICU transfer rates just crashed. Most of the patients would not go to ICU. And we also then became confident in doing things on daycare. So HIDAC, you're done with HIDAC, patient is stable, send off. Do it on daycare. We started doing autologous transplants on daycare. So we've done 12 autologous transplants for myeloma and 1 for multiple sclerosis on daycare, because everything is set. If there's infection, what to do, and patients don't become sick, right? Even if they need granulocytes, they come take granulocyte and go back. They just don't become septic. But we will soon publish this paper and I'll send you the manuscript. This is fine. I'm not going to labor too much on, rapid line removal, but ICU is something that has also helped us. So whoever becomes sick, we brought in a policy for early ICU transfer. Don't wait for the patient to become too sick. Don't wait for them to go on, a rebreather mask. Avoid inotropes in the ward. Avoid it, because we are not intensivists. We don't have the nursing team to do that. They are not trained. They're already stressed. We can't manage. And there was something else that stayed in my head during training. One of our patients, usual febrile neutropenia, when I was doing my DM, had a code blue in the ward, had a cardiac arrest. And Vikram was my guide. And Vikram was on shift that day. And next day, Vikram came and said, no, check the nurse's notes. I am sure the patient deteriorated for 4 or 5 hours. Nobody noticed, right? Nobody noticed. And then suddenly there is a cardiac arrest. And he said, if there is a cardiac arrest in the ward, we have missed something in the previous 6 hours. You do a death audit. So that kind of stayed in my head. And this data was published much later. Where it's very clear as to how soon you shift a patient to ICU and how many patients come back alive. The faster you shift, the better. They are a trained team, right? They can do this better than us. And this was the criteria. So anybody requiring more than just 2 liters of oxygen, just 2 liters, not even 4, 5, 6. I mean, all of us are confident of managing patients up to rebreather mask. We can do it, but our teams can't do it, right? No high flow oxygen in the womb. Hypotension, give 2 fluid boluses. As per ICU protocol, after 2 fluid boluses, if there is still hypotension, you have to start inotropes. Do it in the ICU. All right. So we're really screening patients and anybody who requires airway management. So you feel, sensorium is going down and you have to put in a tube for airway management. Don't do it there. Now with this, of course, what happens is your cardiac arrest in the ward go down. because you're not keeping any sick patients there. And the mortality improves. You're sending the patients to ICU early. And if they recover within 24 hours, in 24 hours, we pull them back. We pull them back equally fast. So it's not that they go there and they hang in the ICU until neutropenia recovers. No. We shift early. And if they stabilize, if these things are okay for 12 to 24 hours, we pull them back next day if required. But we shift them there. And finally, of course, the antibiotic resistance. We conducted a randomized controlled trial. These were our first line drugs, which I was also discussing with Subra in his talk before. And we published this. We took 33 patients in each arm. High risk febrile neutropenia, first line meropenem versus first line ceftaroline versus first line ceftaroline aztreonam. Aztreonam is essential for the notorious NDM positive bugs, New Delhi metalloproteinase. 40% of the isolates in this country are NDM1 positive. 40%. And they don't respond to anything except aztreonam. And when I remember when this paper, which called it New Delhi metalloproteinase, was published, I think in NEJM, our ego was hurt. But that time there were isolated cases. Now 40% of the isolates are, they're resistant to everything except aztreonam. So we thought, let's do a randomized control trial, first line, what works, right? So the 33 patients, again, different indications. And we saw that, in the initial analysis itself, we started seeing some difference. Now, we did this clinical trial because, again, Subra told me that, forget meropenem, you have to go to ceftaroline as first line and maybe even add aztreonam. I thought, well, we have to do a trial. So these are baseline characteristics of the patients, and I'll come to this. So these are the clinical outcomes. We thought if the drug is working, you won't have to step up in 2 to 3 days, right? 48, 72 hours, you don't have to step up if your first line drug is working. So we thought, let's see how many patients had a change in antibiotic in 72 hours, how many days were required for fever to go off, how many became sick, hypotension, hypoxia, transferred to ICU, and how long were they in the ICU, and how many died. Okay, so these were our primary and secondary outcomes. You see, in meropenem, 72% of patients you have to add colistin or polymyxin or change to ceftaroline, whatever. Ceftaroline, half. Kind of correlates with 40% NDM positivity, right? And in ceftaroline astray also 27% we had to change. Okay. All three of them required the same number of days to kind of effervesce. There was a slightly less in ceftaroline aztreonam, 5.5 days, but statistically not significant. Transfer to ICU was dramatically less. So 27% of patients who received meropenem as first drug went to ICU versus 3% versus 15%. I don't know why this happened. I don't know why more patients in the aztreonam went to ICU. I really don't know. Maybe it's a sample size thing, but I don't know. But certainly 27% of those whom we gave meropenem as first drug went to ICU, because on second, third, fourth day, when you add ceftaroline or colistin, by then some of them were becoming sick. Number of days in ICU, whoever had meropenem in the beginning, even if you changed the antibiotic later, they still spend longer in the ICU. Whereas these two spent only 2 to 3 days in ICU. So it does matter what you start with the first spike of fever. And number of patients who completed therapy with the same drug. So 72% of ceftaroline we don't have to change. They complete 7 to 14 days of antibiotic therapy and get discharged. Very few go to ICU, etc., etc. Finally, how many actually became afebrile? Here, the resistance is so high that even if you change after 2-3 days, for 7 days, they are still spiking fever because you've given the right antibiotic later. Whereas if you give this, only 18% are still spiking fever after 7 days. So all of these things, because the longer they stay in the hospital, the more expensive it gets. If they go to ICU, the more expensive. Of course, morbidity, mortality, all of that is there. And univariate analysis told us that if fever was continuing, it's bad. If they were transferred to ICU, it's bad. If they became sick, it's bad. Of course, we all know this, right? Multivariate analysis did not show too much. Again, a small sample size, 33, 33, 33. But those who had lung infiltrates, more got transferred to ICU, right? Which I don't know what that means. Those who had blood culture positivity, that means actual bacteremia going on, more of them got transferred to ICU. So this is what we saw, and today Subra told us that even this is going to be useless. We probably have to move on to whatever it is that is available. However, over 8-9 years, this is our last mortality in high risk febrile neutropenia. When we started, we had about 35% mortality. But with sequential development of this protocol and improvements and whatever we learned from our data, our mortality of high risk febrile neutropenia is right now only 6% or so. Thank you so much. These are the centers that we've developed until now. We've developed 17 hematology BMT departments and hopefully 2-3 more this year. Thank you. We're happy to take questions. Yeah. No, the panel has everything. No, yeah. The important thing about a panel is you have to include as many bugs as possible. So to reduce the cost, many of these labs, they will tell you, so what do you suspect? We'll do a customized panel. We'll only do a PCR for that. That's not how you do NGS. That's not how you do FISH, right? For example, ALL FISH or myeloma FISH, would you say only look for two, breakpoints, don't do four because it's cheaper? It doesn't work like that. We have to understand that cancer cell and a bacteria, virus, fungi, they are identical. If you know your diagnosis, see, in my mind, the diagnosis is not febrile neutropenia. The diagnosis of febrile neutropenia due to Klebsiella resistant to so and so. So if you don't do the proper test, you don't get the diagnosis of the infection, the complete diagnosis. And it's not going to help to do a smaller panel. We have an older analysis showing that. The broader the panel, the better. You have to do everything because we've caught one tuberculosis in blood. We've had 3 aspergillus in the blood with no lung infiltrates, just aspergillus in the blood. You need to include everything for a panel to work. Once a week. Yeah, we use once a week. So half-life, I think, is 5 days. We give it once a week. Everything. We do everything exactly the same. We haven't had a problem with, even granulocyte transfusions we give for haplo. Absolutely no problems. Yeah. So the trial methodology was that if they are on meropenem, if they started with meropenem, we would add polymyxin. And if that failed in 48-72 hours, then we go to ceftazidime avibactam. Or if the culture showed something, right? If the culture showed gram positive, we stop these drugs and we go to teicoplanin. So meropenem would get upgraded to adding colistin or polymyxin, usually polymyxin. Cefta-avi would get upgraded to adding aztreonam. And Cefta-avi aztreonam, if that failed in the 27%, then we have to go by PCR and culture. If those are negative, we add antifungal. So this whole concept that 48-72 hours later it is fungal infection is not right. That is based on the probable fungal infection on CT scan, tree in bud appearance and all that. When you actually do the culture and PCR, you will realize fungal is very, very less, very less. For example, suppose we have a patient of AML induction, right, who's already on POSA prophylaxis, and they are not responding to anything, right? We would typically go to ampho or whatever it is, isavuconazole, amphotericin, whatever. But if the multiplex PCR, more often than not, it shows us a bacteria even after 7 days. So then we decide we are not going to add ampho. We are going to continue POSA prophylaxis because the PCR and the culture is showing us a bacteria. So we are not doing empiric escalation to antifungal and all that. It's kind of like treating cancer without doing tests, if we don't do these tests. We've stopped galactomannan. We don't do galactomannan at all. So what will happen with galactomannan? Okay. Your blood galactomannan is insensitive. By the time it comes up, it is 4 to 7 days after fungal pneumonia. You lost time. Your mortality is going to start hitting the 40% mark. Correct? Bronchoscopy BAL, galactomannan rises in 48 hours. Correct? And you do that, more often than not, we have, the average number, that data is not here. We think that polymicrobial infections are rare. But if you do PCR with culture, you will see almost 20-25% of these are polymyx. So your galactomannan coming positive, you think aspergillus, there may also be Pseudomonas in it, which your galactomannan doesn't tell you, even if you decide to do bronchoscopy, BAL and galactomannan. So how is galactomannan helping you? Right? If you have PCR positivity in a anatomically sterile site, you should trust it. Non-affording patients, then anyways you're going to give things empirically. Even if galactomannan is negative, you will end up adding antifungal, which is what we also do. We also do the same. Non-affording patient, the protocol does not apply, right? But we tell them that, look, this is what we see. And you should understand that the mortality is not going to be 6%, it's going to be 30-40%. And that's real life, and that's all that you can do. We don't do. So again, my first analysis of 34 patients, repeating PCR within 1 week does not help. It does not help. So we repeat PCR if, there is fever, it has gone down, and there is a fresh spike with at least 1 week from the previous PCR. Okay, so there is, because what happens in neutropenic patients is there are bursts, there are showers of bacteremia from the colon. There's transmigration and there's a shower, you will have fever with chills. You give antibiotic, that infection is controlled. Few days later, there's another shower of bacteria. So at least 1 week from the previous PCR, and there has been, the temperature went to baseline. Only then we repeat after 1 week, assuming that this is a new episode of febrile neutropenia. Less than 7 days doesn't help. AML induction we do after day 14 marrow, except children. Because in children, there is some data of, increased relapse. So in adult AML, we use day 14. In children, we don't, but we use granulocytes. No, we don't use. Then we go on to second induction. Yeah. Yeah. Or, either with chemo or venetoclax as a cytokine. Yes. Yes.
And sometimes the blood culture there is the difference.
Yeah. So especially our initial patients, when even the labs were not standardized. See, we have worked, now we've understood there's actually only one lab in the country which does this PCR properly, which is infection lab, INFEXN in Mumbai. Amazing. So we send everything to them. We send the culture. If the culture is positive, they do mass spec. So we just started doing mass spec for, LCMS for bacteria. And they do the PCR. Now they give us a report in your culture if it shows E. coli and the PCR is negative. Okay. Or PCR shows Klebsiella. Then we call them and say that there's something wrong. Right. The good thing is now we have worked this out in so well, especially looking at the sensitivity and specificity of PCR. It's very rare now. Sometimes what happens is culture has gone to a different lab. So a different lab has, it says this is streptococcus, right? But PCR says it's gram negative. Then we pick that culture and send to them, and they sequence it, and they tell us that yeah, we missed it in PCR, right? Or this is not streptococcus, this is something else, which is rare again. So it does happen. It has a very good negative, positive predictor. So if the PCR shows something, you believe it. If it is negative, you don't know what is happening. That happens now in about half of our patients, about 40%, about 40%. But again, that's where, granulocytes help us. So at least they don't become sick. The other thing that we learned is viral positivity in PCR is false positive. So if you get CMV or EBV or, sometimes they would give us HSV, viral. So what I did for the first 50 odd patients, if the virus is positive, then I would tell them to do a quantification or repeat a sample from that site of infection. It would typically be negative. So viral positivity we have learned in PCR you can ignore, right? So what happens is if we get EBV in a patient where you are not expecting EBV, if we get HSV, etc., until we get the quantification, we start that drug. In 2 days, you get the quantification, then you stop. So we react to it, confirm it, and then decide whether to continue. CMV, you're going to react to it, right? And again, this was a learning from the first 2 patients that I had. I spoke to the microbiologist and I said, you are giving me 5 bugs in the blood. I have never seen this. And they said, yeah, because you have never done a multiplex PCR in your patients. I said, but are these genuine bugs? Should I react? I said, yeah, you're getting it positive in the blood, right? Blood is supposed to be a sterile site. I said, yeah, but what about false positivity? He said, it doesn't matter, brother. He said, if you're, a snake in the garden versus a snake in your bedroom. Snake in the bedroom, you're not going to wait and see is it poisonous or not poisonous. You're first going to kill it, right? So if you're getting positivity in bile or blood, so we don't send urine for PCR. We don't send stools for PCR. You can't interpret it, right? But in blood or bile, you want to react. Yes, viruses you should confirm. Bacteria, we have now experience of more than 400 samples. You can trust it if it's done in the right lab. Majority of the lab don't do the multiplex PCR properly.
Yes.
CSF we have done, and we have the data, but again, in our patient group, that's generally rare. So see, this is the data on CSF. So we had 8 patients, 0 culture positivity, 2 we had PCR positivity. And one of these, I don't remember the details, but it was a very weird bug. And we treated and the patient got well, had proper meningitis symptoms. But that bug is so rare, very few, hardly one case report, but the PCR showed us and we treated him. Pleural fluid we sent, but positivity is not great. So I think blood and bile is the right one. No nasal swabs, no throat swabs, no Baylor wash. Just if you want to see what is causing a lung infection, you have to do a bile. Nothing else helps. All right. Any other question? Yeah. I mean, the CT scan has to have some infiltrate. Also, what happens is, if the infiltrate is in one area, then the pulmonologist pulmonologist knows where to go to take the bile sample, right? So that decision we leave to them. And we tell them, then they will say, okay, I'm going to go to this lobe or this segment and put my bronchoscope there and take sample from this. So it's beautiful, right? You're getting a sample from the source. So if the CT is clear, we don't do bar. We are transfusing. So what we do is, for an adult, we keep 8 RDPs or 1 SDP ready. We give half before the procedure, and the other half we continue while the procedure is going on and over. And they were very scared. So there is a wonderful paper on some 400 balls in neutropenic and thrombocytopenic patients, and complications were very less. Our experience is also the same. We have data on, I think, 75, 80 balls. I think only 1 or 2 patients became sick and went on ventilator. Everybody else tolerated the procedure. But you have to convince your pulmonologist, saying, don't worry, I will take care of the platelets. I take the risk and all that. Some of them refused. There's one pulmonologist particularly who refused to do it. And I said, fine, nobody can force you, but then you have to find somebody else. It's like operating on a patient with hemophilia. Right? So, right, hemophilia surgeries. You tell the surgeon, leave the bleeding part to me, I will take care of the factor infusions. It's like doing splenectomy on an ITP patient. You tell the surgeon, you do the splenectomy, I will take care of. In our patients, we have everything, adult, pediatric, everything. Yeah, yeah. Absolutely. See, this is the age range, 1 to 86. Thank you so much. Let's meet over dinner.